about family planning, but getting to the nearest clinic requires crossing an actual Himalayan mountain range.
Yeah, that's not exactly a quick trip.
No, not at all. Or maybe it involves navigating a steep valley that takes hours or even, days to traverse on foot. So, how do you deliver consistent, reliable healthcare when the geography itself is the primary obstacle?
It's a huge challenge.
It really is. Welcome to this deep dive. Today, we are exploring a really fascinating source document. It's the Nepal Primary Healthcare Outreach Clinic Program Report.
Specifically looking at the cross-section program of the Family Welfare Division, right?
Exactly. And our mission today is to unpack how Nepal basically engineered this sweeping, decentralized healthcare network to reach its most isolated populations. We're going to look at what their newly released data reveals about the program's successes and some of the unexpected blind spots the system is currently facing.
And there are definitely a few blind spots we need to get into.
Oh, for sure. Okay, let's unpack this. We usually default to thinking about healthcare innovation as, like, a matter of high-tech machinery, right?
Right, yeah, like MRI machines or whatever.
Exactly. We picture gleaming hospitals or complex digital networks, but in rural public health, the logistical landscape completely shifts the definition of innovation.
It really does. It forces a shift from, technological innovation to purely logistical and social innovation.
Which is wild when you think about it.
It is. And what we are analyzing here is the Primary Healthcare Outreach Clinic Program, or the PHCORC. And just to give you some context right out of the gate, this is not some recent, untested pilot program.
Right, it's been around for a while.
Yeah, this initiative was established back in 1994, which, by the way, is the year 2051 in the Nepali calendar.
Wow, okay.
Yeah, and the entire architecture of it was built from the ground up to conquer the geographic and financial bottlenecks that kept underprivileged communities cut off from basic medical care.
And the way they engineered this solution is just brilliant to me because it addresses the physical reality of the patient. Like, you can't just build a concrete structure somewhere and hope people can hike to it.
Right, because that fails when you're somewhere is like 3 valleys away.
Exactly.
Yeah.
So they created what is essentially a highly coordinated monthly pop-up clinic.
I love that term for it, yeah.
Yeah, it makes sense, right? They take the infrastructure directly to the patients. And the golden rule at the center of this operation is what really caught my attention.
The walking distance.
Yes. These clinics are scheduled at set places, at set times, and on specific dates, all to ensure that their target populations can reach them within a half-hour walk.
And that half-hour metric, honestly, is the linchpin of the entire system.
Really? Just that 30-minute rule.
Absolutely. Think about it. When you guarantee a 30-minute walking radius, you fundamentally alter the psychological and economic burden of seeking healthcare.
Right, because it's not an expedition anymore.
Exactly. For an agrarian family, a day-long trek to a distant hospital means lost wages, neglected crops. It's a huge deal. A 30-minute walk turns healthcare from a severe disruption into just an accessible routine event.
That makes total sense.
And the scope of what is accomplished within that localized radius is surprisingly comprehensive. I mean, they provide safe motherhood services, which includes antenatal and postnatal care.
Which is crucial in these remote areas.
Or completely. And they're distributing crucial iron supplements, checking for danger signs that might require urgent hospital referrals. It's real substantial care.
And they're also handling child health, right? Doing routine growth monitoring for children under 2 years old.
Yes, and actively treating pneumonia and diarrhea right there in the community.
Which, just to pause on that, when you look at childhood mortality rates in isolated regions globally, respiratory infections and waterborne diseases are so often the leading culprits.
They are the big killers, yeah.
So having immediate local treatment for the specific issues, that saves lives without requiring a complex hospital mission.
Exactly. And on top of that, they also handle first aid, minor treatments, and a substantial amount of health education.
Like what kind of education?
We are talking about family planning counseling, adolescent sexual and reproductive health, and STI awareness.
That's a lot for a pop-up clinic.
It is, but delivering that full spectrum of primary care into a pop-up tent requires a very specific human infrastructure. You have auxiliary nurse midwives working alongside paramedics, local NGOs, and a really vital group known as Female Community Health Volunteers, or FCHVs.
Okay, let's pause on that, because with all these different groups, the midwives, the paramedics, the local volunteers, How do they actually ensure the clinics happen every single month?
It's a massive coordination effort.
Right. I mean, you are relying on dozens of different people to hike out to a specific spot on a specific day carrying medical supplies. Like, if you've ever struggled with supply chain management in a standard office building.
Oh, don't even get me started.
Right. Try coordinating medicine delivery via a half-hour walking radius in the Himalayas. It seems basically impossible to maintain consistently.
Well, it requires a master class in decentralized logistics, that's for sure. And it hinges entirely on those female community health volunteers we mentioned.
How so?
Well, the central government is not micromanaging every single outreach clinic. That would never work. They partner directly with local level governments. And the FCHVs, they are local women, chosen by their own communities.
Oh, so they aren't outsiders flying in.
Exactly. They know the terrain, they know the families, and most importantly, they hold the trust of the community.
That is so important.
It's everything. When you are discussing sensitive topics like reproductive health or family planning in a conservative rural area, an outsider handing out pamphlets often faces deep skepticism.
Yeah, people would just shut down.
Right. A trusted neighbor, however, bridges that cultural gap. They are the social glue that ensures the community actually shows up when the medical professionals arrive with the supplies.
Okay, here's where it gets really interesting.
Oh, the data.
Yes, the data. The report actually provides the scorecard. We aren't just reading about the theory of how this is supposed to work. We actually have the hard data from the fiscal year 2080-81 to examine the reality of its execution.
And the numbers are pretty surprising.
They are staggering. So the conduction rate, meaning the percentage of these scheduled pop-up clinics that actually took place as planned nationwide, it hit 93.31% in that fiscal year.
That's incredible consistency.
93% in the Himalayas.
And to fully appreciate that number, you have to look at the baseline trajectory.
What was it before?
Just 2 years prior, in fiscal year 2078-79, the national conduction rate was 86.3%.
Okay, so that's a huge jump.
It is. Closing that gap in such a challenging topographical environment means they have successfully tightened their supply chains and really improved local coordination. And when you break the data down by province, the logistical execution becomes even more apparent.
Yeah, I saw this. Gandaki province led the entire country.
They did, hitting an execution rate of 99.11%.
That's almost every single scheduled clinic in an entire province actually happening.
It's practically flawless execution.
But, and we have to look at the other side of this data, right? While the national average is climbing, Karnali province is lagging behind a bit.
Yeah, only hitting an 89.16% conduction rate.
Right. And when you dive into the actual service users like, the number of individual patients showing up there is a striking discrepancy.
Yeah, the provincial differences are wild.
Provinces like Lumbini saw surging user numbers, with over 556,000 people utilizing the clinics.
Massive volume.
But in Karnali, which only had roughly 148,000 users, and in Sudapashim, which had about 378,000, those numbers actually represent a decrease in total service users compared to previous years.
Yeah, the data clearly shows a downward trend in total patient volume for those specific Western provinces.
Wait, I have to challenge the success narrative here for a second.
Okay, go for it.
If the foundational mission of this program since 1994 is to reach the most isolated populations, aren't provinces with dropping user numbers a massive red flag?
It definitely looks like one at first glance.
Right, because Karnali is known for its exceptionally difficult terrain and remote communities. If the clinics are supposed to bridge the gap for those exact citizens, why are fewer people showing up? Is the logistical system failing them?
This raises an important question, and is the natural conclusion to draw when you only look at the top-line headcount.
Right.
It is very easy to see a drop in total humans walking through the door and assume a failure of access. Like, oh, the system is breaking down.
Exactly what I was thinking.
But to understand why overall user numbers might drop in certain regions, we have to analyze consumption patterns. We need to look past the sheer volume of people and examine precisely what specific services they are utilizing when they do arrive.
Okay, so what does this all mean when we look at the breakdown?
Well, diving into the specific service utilization from fiscal year 2081 reveals absolutely fascinating behavioral shifts.
What kind of shifts?
First, general treatment visits surged nationwide. They went from roughly 1.08 million visits the previous year to over 1.32 million.
Okay, so people are utilizing the clinics for general acute illnesses more than ever before.
Exactly. The demand for curative, immediate need services is undeniably expanding.
But then you look at the preventative and routine visits. Antenatal checkups, like the routine pregnancy visits, dropped from over 137,000 down to about 130,000.
Which is a notable dip.
And vitamin A distribution for postpartum women dropped from around 21,000 to roughly 18,000. But the data point in this report that completely stopped me in my tracks, it has to do with family planning methods.
Yes. The family planning metrics offer the most profound insight into how patients are adapting to their geographic reality.
Listen to this shift in behavior. Condom usage through the outreach clinics dropped by over 100,000 pieces.
That's a huge drop.
It is. And women utilizing traditional daily contraceptive pills dropped from almost 51,000 down to around 47,000.
Right.
So daily or single-use family planning methods are in decline. But users of what the report calls the depot method, which is DMPA, an injectable contraceptive, saw an explosive spike.
Completely unprecedented spike.
It jumped from 92,223 women using it to an astonishing 424,309 women.
I mean, we are analyzing a nearly 400% increase in the utilization of one specific injectable contraceptive in a single year.
That's just wild. I was trying to conceptualize why this specific shift happens so aggressively.
What did you come up with?
It's like shifting from a daily subscription that you have to constantly manage to a quarterly set and forget model.
Oh, that's a great way to look at it.
Like if you are taking a pill, you need a constant, uninterrupted supply. You have to remember it every single day. An injection, however, lasts for months.
And if we connect this to the bigger picture, taking that subscription analogy further, consider the stark logistical reality of the supply chain here.
Right, the mountains.
Exactly. Think about the physical terrain these patients and providers are navigating. Shipping and storing bulky boxes of condoms or ensuring a continuous, unbroken supply of daily pills to a valley that might get cut off by monsoon floods. It is deeply precarious.
Oh, I didn't even think about floods.
Yeah, if the supply chain falters for a week, or if a woman misses one clinic day because of a washed-out trail, her chosen family planning method fails entirely.
The consistency is fragile.
It is highly fragile. Depot, the injectable contraceptive, changes the math entirely. It is an intramuscular injection that provides 12 weeks of protection.
12 weeks. That's a quarter of the year.
Right, so a 400% spike in its use does not just indicate that the medication is popular. It indicates that patients are making highly rational, strategic decisions about their own health care based on their environment.
That makes so much sense.
They are actively moving away from services that require high-frequency maintenance and opting for interventions that provide long-term stability with fewer touch points.
Which completely reframes the dropping user numbers we discussed earlier.
Exactly.
The system in regions like Karnali isn't necessarily seeing fewer people because it is broken. It is seeing fewer total visits because the treatments themselves are becoming more efficient for the patient's lifestyle.
Precise.
A woman who used to visit the pop-up tent multiple times a year to restock pills is now visiting maybe 4 times a year for an injection. She's effectively managing her health with fewer trips down the mountain.
The community is maximizing the efficiency of the tool provided to them. It is a sign of a maturing healthcare consumer base, adapting to optimize their time and security.
That is just brilliant. But even with those adaptations, the system obviously has its flaws, and the report itself is thoroughly transparent about them.
They don't sugarcoat it, no.
They actually conducted a formal SWOT analysis evaluating strengths, weaknesses, opportunities, and threats to audit where the outreach program stands today.
And they document their strengths accurately. The strategic locations targeting marginalized communities are highly effective, and the foundational partnerships with local-level governments provide the necessary operational support.
But they also get into the weaknesses.
Right. They do not obscure the systemic weaknesses. The report openly acknowledges that targeted sessions are not always scheduled up to the mark in certain regions.
Meaning they miss their targets.
Yeah. They also point to inadequate supervision and monitoring from both the provincial and federal levels. When central oversight wanes, you start to see the fluctuating conduction rates we observed earlier.
There was one specific weakness listed in that SWOT analysis that jumped out at me, mainly because it feels entirely counterintuitive given the logistical triumphs we just discussed.
Which one?
The report explicitly states, as a documented weakness, that this outreach program is not effective in urban settings.
Ah, yes. That is a highly revealing admission regarding system design.
I just found myself asking why that would be the case. Like, if this pop-up model is so bulletproof that it functions in isolated mountain communities where logistics are an absolute nightmare, why does it fail in a city?
It seems backwards, right?
Totally backwards. In an urban center, everything is closer. The roads are paved, the supply depots are nearby, the workforce is centralized. It should be easier, not harder.
Well, it comes down to understanding the philosophy of barrier removal.
Okay, unpack that for me.
The primary healthcare outreach clinic is a bespoke, highly specialized tool. It was meticulously engineered to conquer one specific enemy, and that is physical distance.
The 30-minute walk.
Exactly. The entire architecture, the 30-minute walk, the monthly scheduling, the reliance on local volunteers is all designed to bridge a geographic gap. But when you deploy that exact same tool into an urban setting, the primary barriers to healthcare fundamentally change.
The mountain is no longer the obstacle. It's like you don't use a snowplow to clear a traffic jam.
That is exactly the right way to frame it. In a city, the barrier is rarely a physical distance of a half-hour walk. You likely have several permanent clinics or pharmacies within a 10-minute radius.
True.
The friction in an urban environment comes from time constraints, like working rigid factory shifts that just do not align with a monthly pop-up schedule. It comes from crowding and long wait times at existing facilities.
And it also has to be a matter of anonymity, right?
Absolutely.
If you live in a dense city neighborhood, you might not want to walk into a pop-up tent in your local square to ask for reproductive health advice where literally all your neighbors can see you. You would much rather go to a private pharmacy a few streets over.
The social dynamics are entirely different. Applying a tool built for rural isolation to an urban landscape ultimately misallocates resources. It demonstrates strong institutional self-awareness from the program directors to formally acknowledge that limitation. A successful system must understand the specific shape of the barrier it is trying to break.
It is a fascinating journey when you step back and look at the whole picture. For you, the listener, whether you are analyzing public health data or looking at systems within your own industry, the lessons here are really profound.
Without a doubt.
We started with a vision from 1994, the idea that you could conquer staggering geographic obstacles by simply guaranteeing a 30-minute walking radius. Over the decades, that concept scaled into a nationwide logistical network that successfully served over 2.7 million users in a single year.
Which is an incredible feat on its own.
It is. We explored how a decentralized supply chain hit a 93% success rate by leaning on the social trust of local volunteers. And perhaps most importantly, we saw how the patients themselves use data to drive change, triggering a 400% surge in long-term contraceptive demands because it practically fit the reality of their remote lives.
The core takeaway here is that effective systems must meticulously adapt to the specific evolving realities of their users. You cannot assume you know what the barrier is from a distance.
Right.
You must constantly analyze consumption data, like that massive shift from daily pills to quarterly injections to verify how user needs are actually changing on the ground. Data is the only objective lens to see if the environment beneath your operation is shifting.
It is a masterclass in observing the behavior of the people you are trying to serve, rather than just forcing a system onto them. But, it also leaves us with a pretty compelling puzzle for the future.
What's that?
Well, the report admits these outreach clinics are not effective in urban settings. But as Nepal, and really the rest of the world, continues to urbanize at a rapid pace, it makes you wonder. Yeah.
How will a healthcare system built entirely on conquering rural isolation adapt when those isolated populations eventually move to the crowded cities? When the mountain is no longer the obstacle, but the sheer density and anonymity of the city takes its place, well, it is a whole new kind of barrier.
It's going to require a completely different kind of innovation.
Exactly. And that is a shift worth thinking about long after we finish today. Thank you so much for joining us on this exploration. It's been a deeply insightful conversation.
Thanks for having me.
We'll catch you next time.